So on behalf of the ALL working acute leukemia or lymphoblastic leukemia working party of the Japanese hematopoietic transplantation and cellular therapy, I presented the data on the T-lineage hematopoietic stem cell transplant outcome for T-ALL and T-LBL. Actually, the T-lineage ALL and LBL are regarded as a single disease entity according to the WHO classification, both from 4th and 5th edition. But actually, these diseases have distinct characteristics. So we usually divide ALL and LBL by the bone marrow blast percentage. The threshold is usually 20 to 25%. And most of the ALL are from B-cell lineage, and only 20% of the T-ALL were there, while most of the LBL were from T-cell lineage. So that's the difference. But usually, patients with T-ALL and T-LBL receive the same ALL type chemotherapy, and some of the patients who are at high risk of relapse or primary refractory for induction failure, were planned to receive the allogeneic hematopoietic stem cell transplantation. So recently, autologous hematopoietic stem cell transplant for T-ALL is not standard. However, so some of the institute and some of the investigators still perform the autoSCT for LBL. So the plan for stem cell transplant is different from these two diseases. However, due to the rarity of the diseases, the limited data is available. So we conducted the retrospective database survey using the Japanese transplantation large database called the TRAMP database. So we identified the first transplantation for the age 16 or more for T-ALL or T-LBL between 2000 and 2017, except for the autoSCT for T-ALL. The primary outcome was the overall survival, and secondary outcome was disease-free survival, non-relapse mortality, and cumulative incidence of relapse. So actually, we identified the 1,345 patients in total, and over 800 T-ALL after allo, and 400 T-LBL after allo, and 130 T-LBL after auto. So age at transplant was median age at transplant was 32. However, in the auto LBL group, the median age was 49 years old. So it's significantly higher. While the performance status was worse in the allo LBL group, and the disease status were also different. So in the allo LBL group, almost half of the patients were in non-CR at SCT, and while the other two groups were 13% of non-CR patients. The median follow-up of 4.5 years, we evaluated the survival outcome. So in the entire cohort, the overall survival and disease-free survival at 4 years was comparable between T-ALL and T-LBL group. It's almost 50%. Non-relapse mortality was lower in T-LBL group, and relapse ratio was higher in LBL group, T-LBL group. In T-LBL group, when we divided for allo-LBL and auto-LBL group, the significantly lower survival was observed in the allo-LBL group due to the higher non-relapse mortality and a comparable CIR, cumulative incidence of relapse. But when we look at the patients, focused on the patients at the first CR at transplant, only for CR1 patients, the overall survival and disease-free survival were comparable among the three groups, while the non-relapse mortality was significantly lower in auto-LBL group and a little bit higher cumulative incidence relapse in auto-LBL group. So result in overall survival and disease-free survival were almost comparable, around 70. So when we look at the non-CL patients at SCT, the survival data were almost comparable, almost around 20 to 30% of long-term survival among three groups. Again, we have observed the lower non-relapse mortality in the auto-LBL group, a little bit higher relapse incidence in auto-LBL group. So after the evaluation of multivariate analysis in T-ALL, we identify the poor prognostic factor as the performance status 2 or more at the SCT, and also the disease status in non-CL or CL2 or more at transplant. And also we identify the conditioning regimen using non-TBI, a myeloablative conditioning without TBI, total body irradiation more than 12 gray. In T-LBL, we also evaluated the multivariate analysis, and we also found the PS and the disease-free survival were two strong poor prognostic factors. So the summary of my presentation is just the HCT outcome were comparable between T-ALL and T-LBL. Although the higher age at transplant, auto-LBL group had a comparable survival after transplant. So in the fit elderly patients, the auto-HCT can be a suitable option. However, our data is just a retrospective analysis, so we need a further analysis by using in the future prospective studies. That is one of the summary for my first presentation. So actually, as a transplant physician, I have lost a lot of patients after the transplant due to the non-relapse mortality. So including some of the T-LBL patients. So if the patients did not need allo transplant and it's enough for auto transplant, I think some of the patients can be saved. So I think evaluation in the near future will be necessary.